G'day, welcome to step number 4, lesson number 2, strapping options. Here's what you'll discover. The single strapping option I use for assessing the mechanical cause of plantar heel pains, the recommended steps for using this strapping method, how to interpret your patient's feedback from the strapping, and the longer-term treatment to use based on your patient's feedback. Please download the cheat sheet for this lesson and keep that for your reference. Plantar heel pains we see in our clinics commonly have a mechanical etiology that we'll often consider treating with orthotic therapy. It's for this reason that trialling your patient's response to a mechanically based treatment through a trial process is a smart thing to do. You see, if you and your patient can get some real-world feedback of your strapping treatment trial, you'll both be more confident in the longer-term treatment plan. Make sense? Great. So, the taping technique I'm going to use is the low-dye taping technique named after Dr. Ralph Dye, podiatrist in the US. The mechanical objective of low-dye taping is to decrease the mechanical stress on the plantar fascia and limit subtalar and mid-tarsal joint pronation, which are thought to contribute to plantar heel pains. This reduction in mechanical stress is achieved by plantar flexing the first ray, everting the forefoot relative to the rear foot, and supinating the rear foot. Now, there are a number of versions of low-dye strapping to achieve the above effects. I'm going to show you the TED version, and this has 3 key benefits. It uses less than half of the amount of tape nearly every other version requires. It takes about 1/3 of the time to apply, and it's dead simple to do when you know the precise steps. And they are: the first step is to prepare the lengths of tape in advance. Apply the single length of tape that achieves the 3 mechanical objectives, and reinforce that single action tape for maximum effect and durability. I'm going to insert a video demo of the TED version of low-dye strapping that clearly shows each step of this taping method. Now, this video was filmed in a workshop that I ran in Italy, so you will hear a few inserts from my translator at the time. I'll catch you on the other side. The first thing we do is get the pieces of tape ready. So that's going to be the active piece, and then we need to lock the tape to the foot. So these will be the extra pieces. Layla, just keep your leg there for me, please.
Chiede a Leila di tenere il piede così.
So the first piece. Medial side of the metatarsal head. Then plantar flex the foot. So it's like supinate the foot. Oh no, you don't have to, Layla. I'm doing that. Here. And then wrap around the lateral column and come back up the medial column.
Quindi il primo pezzo di tape parte dalla base, dalla testa, scusate, del primo metatarso, va in giù in flessione plantare e in supinazione il piede, deve essere passiva, quindi non la deve fare il paziente, gira intorno al calcagno e torna dietro sempre nello stesso punto di partenza.
So this is pulling first metatarsal head back posteriorly instead of the medial column going anteriorly.
Quindi questo primo strap.
And that's it. Now, if Layla gets up and walks, it'll all just come unstuck. So we just need to make it stick and hold in place. first piece around the back of the heel is because when she slides her foot in and out of shoes, that back part comes loose. So this is just to give more surface area to hold the back of the heel tape in place. Then there will be two locking pieces that hold the first active one in place.
E poi ci sono altri due ancoraggi distali che servono a bloccare e mantenere il bendaggio fatto in precedenza al proprio posto.
When we look at this foot, the first thing you'll see is the big toe. The hallux valgus is now straight. There's always a gap in between the first and second toe. Okay, my best recommendation is to use the low-dye strapping as the only trial intervention so that you can be most confident that any changes reported by your patient resulting from the single intervention and not another intervention or combination of interventions. Strapping does have a limited lifespan, especially when it's being walked on. What I've found effective is to instruct my patients on the following. Aim to keep the strapping on for 3 days. Do your best to keep it dry. So use a plastic bag with a towel for showering, or bathe with the foot dangling out, or blow dry the strapping after having a bath or a shower. Take note of any and all changes over the next 3 days while the strapping's on. Then remove the strapping after 3 days and take note of any and all symptoms for the next 3 days without the strapping. And then review in 1 week's time. Okay, so it's 1 week later and your patient returns for their follow-up visit. One of 3 things will have typically happened. They'll either have felt better with the taping, felt worse with the taping, or felt no different with the taping. If they felt better, your job is then to reproduce the mechanical effect in a more convenient form than wrapping their foot up in sticky elastoplast. This will usually be through a form of orthotic therapy. If they felt worse or no different, you need to trial another option for a more therapeutic benefit to come up with a positive treatment option. Now, I always recommend advising the patient of the advantages of doing this kind of trial run first. So I use a script and it goes like this. So Mary, based on my findings so far, it looks like the cause of your problem is, and insert the etiology. For example, it might be stress on the long ligament of the foot, the plantar fascia. Mary, in theory, your heel should respond best to a reduction in this stress. Now, of course, you're not a theory, so I recommend we do a trial first and get some real-world feedback from your body, and then we can proceed with more confidence that we're on the right track. How does that sound to you? It's important to get agreement from your patient. This also helps you in managing your patient's expectations by not over-promising and under-delivering with a service that didn't help. See, if they come back with a, no, that tape didn't help, you're able to respond positively with a, okay, great. Now we know what it is that's not going to get you back on the dance floor. Good news is, I have other options for us to test. And on you go. This is so much more manageable than having an irate patient who has no idea that you do have other options up your sleeve. Make sense? Great. Okay, so in this lesson, you discovered the single strapping option I use for assessing the mechanical cause of plantar heel pains, the recommended steps for my method of low-dye strapping, and how to interpret your patient's feedback from the strapping, plus the longer-term treatment to use based on your patient's feedback. In the next lesson on stretching, we're going to dive into the most effective diagnostic and treatment stretches for plantar heel pains. See you there.